and fellow echocardiographers and leaders and legends in echocardiography from all over India. We first of all thank father of echocardiography in India, Dr. Satish Parashar, for having initiated this great initiative of having monthly webinars on echocardiography, and each branch of Indian Academy of Echocardiography has its charms in rotation. And this month, we are having the IAE webinar from Madurai branch of Indian Academy of Echocardiography in association with Tamil Nadu Cardiological Society. Now, we have two interesting presentations. One is pleiotropic presentations of hypertrophic cardiomyopathy, and the second is a ladies topic, that is cardiovascular, echo-guided management of prosthetic heart valves during pregnancy. Let me introduce myself as the editor of, I was given the privilege to be the editor of Indian Academy of, textbook of Indian Academy of Echocardiography. And we have many publications. We have come out with the second edition of this now, just now. I request all the fellow echocardiographers and students and postgraduates to have this book, handy book, at your bedside during performance of echocardiography. And my co-chair is Professor Dr. G. Selvarani, Professor of Cardiology, Madurai Medical College. She has 28 years of government service to her credit and 10 papers as first author. And her interest is predominantly in fetal echocardiography. She is the finance secretary of Indian Academy of Echocardiography, Madurai branch, and handles the finances very well. As you know, ladies always handle it very well. Now we have interventional cardiologist from echocardiographer. He takes echocardiographic classes, conducts course for fellow echocardiographers in Ramnad, the remote city of God city of Ramnad, for the echocardiographers, and he earned the wrath of interventional cardiologists for this also. And he is a member of IMA and IAE and the European Society of Cardiology, American Society of Cardiology, and the American College of Cardiology, and SKY, and he has organized so many webinars and CME programs. He has written textbook on emergency medicine, critical care medicine, and clinical cardiology, and he has been awarded Doctor of Excellence from none other than APJ Abdul Kalam. He is KG Achiever Award from KG Foundation, Star of EPI Award from SEMI, COVID Warrior Award from MMF, Lifesaver Award from Rotary Club, Lifetime Achievement Award from MMRCH, D.Lit from London Tamil University. And we have second speaker, who is Dr. Megilla, Cecily Mary Megilla. She is an interventional cardiologist, and she is professor of cardiology at Vamandurar Institute of Super Specialty Hospital at Chennai. She has earned the first prize for best challenges cases and Asia Pacific conferences and interventional council, and she was awarded DP Basu Young Award, Young Investigator Award in Cardiology by Central Health Minister, awarded first place in oral presentation of Indo-Japanese CTO Summit, co-authored 30 chapters, including a chapter in our own textbook of echocardiography. So with this introduction, let me call upon Dr. Jabar Farooq with his talk on pleiotropic echocardiographic presentations of hypertrophic cardiomyopathy. Dr. Jabar Farooq, please share your screen and start your session.
Is it visible, sir?
Yes. Zoom it. Full screen. Make it full screen. Yes, very good.
Yes.
It is moving, sir, actually. So, good evening, ladies and gentlemen. At the outset, I would like to thank Indian Academy of Echocardiogram for giving such a wonderful opportunity to present this an important topic, a pleiotropic presentation of hypertrophic cardiomyopathy. So, first of all, let me thank you so much, IAE Madurai. Congratulations for getting a Best Chapter Award for 5 consecutive years because of the indomitable spirit in academic. We get it from Professor V. Amudan, who is a correct prospective for a Lifetime Achievement Award by IAE. And also we get a lot of encouragement from People's Professor, Professor Veeramani, Professor Balasubramaniam, and also a dynamic woman cardiologist, Professor Dr. Selvarani, which is always encourages to do a good academic work. And also I thank Professor Ramesh from GRH Madurai for providing inputs. Hypertrophic cardiomyopathy is the most common inherited cardiomyopathy. It exhibits left ventricular obstruction, left ventricular hypertrophy in the absence of obvious cause, like cardiac causes like aortic stenosis or coarctation of aorta, subaortic membrane, supraortic membrane, like systemic causes like systemic hypertension, amyloidosis, or metabolic causes like hemochromatosis, Fabry's disease, or athletic heart. So this should be absent. You have to rule out all these things, and it has a varied phenotypic expression. It can be obstructive or non-obstructive varieties. We have this have a pleiotropic presentation because we have a single gene with multiple expression. Actually, it has a 150 mutation with jet set, 13 genes, 4 protein. It has, because of multivariate and multifaceted presentation, it has more than 75 names. So recently, we have an article at JAS, which is giving a big hype to our the echocardiographic assessment and hypertrophic cardiomyopathy with a multifaceted presentation. Actually, it affects 1 in 500 people. It can have a presentation to be asymptomatic to sudden cardiac death. The annual mortality varies from 3 to 4%, children 6%. There is a genetic transmission with autosomal dominant inheritance in 50%. I am going to show you a series of cases of how the echo plays an important role. This patient is getting walked into an echocardiographic department for evaluation. Actually, look at this echo giving an obvious diagnosis of a hypertrophic cardiomyopathy. In 2D echocardiogram, we have a parasternal and long axis view. We give a lot of information here. Actually, look at this asymmetric septal hypertrophy with a sparkling echogenicity of a septum, and this finding is very specific for cardiomyopathy, and also it gives an extent of myocardial involvement. You look at this. Actually, this also gives an idea on the phenotypic variety. Actually, we have this convexity towards this cavity. We have a cavity obliteration, and this suggests that it is a reverse curve type of a phenotype, and we have an obstruction here in the subaortic region. The most important here, look at this mitral valve, which is moving anteriorly, and in 2D itself, we can make out this systolic anterior motion, or SAM, which is the most important, the hemodynamic mechanism of this hypertrophic cardiomyopathy. And 2D also, we can look at this LA dilatation, and carefully you can look at this RV involvement. RV cavity is normal, and aortic wall obviously appears to be normal in 2D echo. And minimal, you can see this is the posterior wall thickening also. But predominantly, there is a thickening at the mid-ventricular interventricular septum. The maximum interventricular the thickness is at the mid-ventricular site. So this is what we get it through this echocardiogram. And color Doppler, if you look at this, actually, it shows a subaortic turbulence there. Actually, exactly at contact with this, you have a mitral valve leaflet to the septum. Septal mitral valve contract, and which is showing this, the dynamicity of this obstruction and mechanism of obstruction, which involves the mitral valve, the anterior motion of the mitral valve, and having a contact with the septum that determines the the severity of obstruction and prognosis actually. So we have this. Apart from that, we can look at this. The color Doppler is showing a MR. The MR has a multiple mechanism in hypertrophic cardiomyopathy. Basically, the anterior mitral leaflet is anteriorly displaced, elongated, and we can look at this. It also produces some amount of bulge into the LA. And apart from this, actually, we have a subvalvular apparatus which plays an important mechanism. We have incomplete cooptation of anterior mitral leaflet to the posterior mitral leaflet, and that is due to the suction effect or injury effect or a dominant force of anterior mitral leaflet during the contracted phase of ventricle in this hypertrophic cardiomyopathy actually. So this is another important information what we get for the diagnosis. Is simple. This is the remote echocardiogram across the aortic valve. This has also been very much explored here actually. Look at this actually. The aortic leaflet, there is a mid-systolic partial abrupt closure of the mitral valve, the fluttering of the leaflet. This is very specific, looks like an artifact, an important remote finding, which gives an idea on this cardiomyopathy. I look at this, mostly the MR jet goes towards posteriorly, it is posterior directed jet actually. It gives you idea about the mechanism of MR actually, because the hypertrophic cardiomyopathy, when it is related to the cardiomyopathy, it is usually a posterior jet. But when you have a jet anteriorly, or when you have another abnormal jet, you have to suspect an associated mitral abnormality actually. This is an important slide actually, mode echocardiogram. Look at this, there is an asymmetric septal hypertrophy, and we have a systolic anterior motion which can be graded using this mode. And there are various formulas which are available to grade this SAM actually. Basically, you look at this, the SAM movement actually, the duration of septal contact actually gives an idea about severity of obstructive cardiomyopathy. Apart from that, the anterior mitral leaflet initiation, starting of SAM to the septal contact time, we have a ratio for calculation actually, but there is a simple grading which is available, grade 1, grade 2, grade 3, where when the anterior mitral leaflet distance to the septum is more than 10 mm, it is grade 1, it is less than 10 mm. It is grade 2, and it is less than 10 mm, it is there, contact is there, more than 1/3 of the systole, it is grade 3, and it gives the severity correlate with the prognosis actually. And this is a septal movement actually, anterior mitral leaflet SAM, which is well demonstrated, and mode echocardiogram can be graded by this by this technique actually. MOD is very useful in grading this SAM and prognosticating the hypertrophic cardiomyopathy. Usually there is a cavity obliteration. This MOD shows that the ventricular cavity is obliterated, and this is most important because when you measure the ejection fraction is usually abnormally high actually, because most of this the ejection fraction measurement by MOD technique involve the LV and diastolic and systolic dimension as a ratio. So when there is a smaller cavity, it is exaggerated. We have highly exaggerated EF by this, because this if you want to assess the LV ejection fraction for hypertrophic cardiomyopathy, better to use other modality to get an accurate. In spite of that, actually, if you have a normal ejection fraction, even with normal ejection fraction, hypertrophic cardiomyopathy, usually they have systolic dysfunction. Diastolic abnormality is the must actually. This is, you can again show this is a 4-chamber apical view. I can look at this actually. This is the reverse curve type, the cavity obliteration. You can look at this convexity towards the cavity, and you can look at this anterior mitral movement, which is having a complete contact actually for a long duration actually. The length of contact also give an idea about severity of LV outflow obstruction, and we have MR mild, MR posterior jet. And this is important, the Doppler, continuous wave Doppler actually, which give you an idea on gradient. The most important here is the shape of this actually. The shape is, dragger shaped, or the scimitar shaped, or a shark fin shaped type actually of a gray. This picture we get into this Doppler actually. And most important, mainly because you understand the mechanism of this gradient actually. Initially, you have the hypertrophic cardiomyopathy, there won't be much gradient actually as the anterior mitral leaflet moves towards the septum actually. When they have a septal contact, the gradient increases, and that produces the shape actually. So again, you can look at this outflow gradient here by color Doppler. And the aortic leaflet is here normal, LA dilatation, and posteriorly directed jet. And this is a provocative maneuver which will require for the demonstrating the propagative nature of this dynamic obstruction, actually, there is an increased gradient. Maneuvers which can increase the gradient are the squatting to start, the maneuvers which decreases the LV preload or afterload or increases the contractility, like the squatting to standing position, or the previously people used to use amylonitrate. Valsalva maneuver, strain phase is very commonly used, and that can increase the gradient, actually. And most important here is you want to understand, one of the important point here to understand is when you measure the gradient, you have to rule out this MR contamination. Actually, MR contamination is one of the feature we get it to you here. Actually, with placing the cursor and reduce the gain will avoid this contamination. Or if you have a significant MR, it may overestimate the gradient. Actually, here you look at this. There are two shadows here, one from the LV, the outflow, and another from the LV inflow, mitral regurgitation. Actually, so this is one of the important feature which has to be kept in mind when you assess the severity of hypertrophic cardiomyopathy. This is the patient suprasternal view to rule out the coarctation. There is no gradient. So you can look at this actually, how much information we get it from two-dimensional echocardiogram when you have parasternal long axis and the short axis view. Short axis view will be useful to assess the quantum and of the myocardial thickness, actually. And there are previously people used to report with the thickness at the anterior septum, the posterior septum lateral wall. Now the maximal thickness is taken as a measure. The maximum endostolic thickness is a measure for the diagnosis, which is normally more than 15 mm, more than 30 mm. It is a high risk individual, actually. So MR, I told you actually in hypertrophic cardiomyopathy, the mechanism involved the two mechanisms here, intrinsic mechanism of mitral leaf flat abnormalities. The gene positive state, there is a disorganized pathologically, and also the papillary muscle head sometimes get attached to the mitral valve leaflet, restricting its movement and incomplete cooptation to the posterior mitral leaflet, actually. So here we can look at this. There are various scores are available. We have a Wiggle score, we have a Sprito score to grade the thickness, actually, and we have a Sprito-Maron score. Depending upon that, we can say it's mild, moderate, or severe thickness. Whatever may be the method used, the maximum wall thickness has to be evaluated at any level of left ventricle. The maximum wall thickness of the left ventricle at any level should be more than 15 mm for diagnosis in the absence of other secondary causes, actually. So this is again told you actually scimitar or a dragger appearance mechanism also I told, actually. These are the other varieties what we have here. We have a midventricular obstruction, and also the echocardiogram give you a presence of LV aneurysm, which is prognostically important, high risk status, actually. The assessment of a hemodynamic status is more important. Here we have a 43-year-old male, shortness of breath and exertion, and X-ray, the ECG shows left ventricular hypertrophy with a strain, and we have here increased LV, the IVS thickness around the 34, actually, which is significant, severe septal hypertrophy with a SOM, and LV mass is grossly increased, actually. We have a diastolic abnormality. The echocardiogram plays an important role to assess the diastolic function. Here we have the deceleration time of 55, and the tissue Doppler, the E velocity is 4, E lateral is 6, and the E bar E-dash ratio is 16, lateral is 14, average is 14, actually. And here we can look at the TR velocity is 3.6, TR gradient is 54, and left atrial volume index is 75 ml per meter square. And we have this important parameter too in hypertrophic cardiomyopathy, that is the pulmonary vein Doppler. We have the atrial regurgitance to AVM duration. These are the criteria for diagnosis of diastolic dysfunction in hypertrophic cardiomyopathy. The average E bar E ratio is more than 14, and LA volume index more than 34. Pulmonary vein atrial reversal time AR to AR duration is more than 30. Peak velocity TR jet of continuous Doppler more than 2.8. Accordingly, this also is graded. Grade 1, it is less than 50% positive, and grade 2, we have inconclusive state, 50%, just 50% it is inconclusive. When you have 3 criteria like this, more than 50%, it is grade 2. And when you have more than 2 criteria fulfilled with the E bar A more than 2, and tissue Doppler shows the lateral velocity of 7 and septal velocity of less than 10, it is grade 3, actually. This parameter can be applied irrespective of presence or absence of dynamic obstruction and MR, except of a few moderate MR where the AR to A duration and peak velocity of TR are still valid, actually. This is another important finding from echocardiogram, lack of significant EO velocity variation less than 20%. Propagation velocity here it is with 35, less than 45 is indicative of diastolic dysfunction. I told you this pulmonary SD ratios 16%, less than 40% indicative of LA pressure elevation more than 50. And strain is very important, which will give you the extent of involvement. Here is 4.2, and also it differentiate from other differential diagnoses like hypertension or especially the metabolic disorder actually. So in another case, we have actually in variant, look at this actually, it is different from this parasternal long axis view. We have the hypertrophied basal septum actually with the SAM here actually, and mitral regurgitant jet is much more moderate MR actually with a turbulence such as the LV outflow and significant MR here actually. If you look at this actually, it involves the predominantly basal septum, a sort of a sigmoid curve actually. We have a ovoid, the distal cavity shape actually, and LA dilatation. There is a SAM here actually. SAM is very significant here. Septal contact is more than 1/3 of the systole actually, and this is an MR, posterior jet MR, and we have this echo rules out a possibility of any aortic valve involvement there. There is no aortic diseases here, and this will quantify the extent of the hypertrophy here actually. This is again cavity obliteration with a SAM, and here you can look at this actually. This involves the basal septum, and this is ovoid here actually, a sigmoid type of hypertrophic cardiomyopathy is a phenotypic variant. This has a genetic and also a clinical relevance actually. Here gradient is around 53, and there is a diastolic abnormality, a restrictive pattern, and with it's provocative here actually increase in the gradient, and tissue Doppler velocity is reduced. And again, here you can look at this, the lower septum is the oval here, mainly the basal septum involvement, a sigmoid variety of hypertrophic cardiomyopathy. This is a different phenotype of variety of hypertrophic cardiomyopathy. Echo plays a very important role here. Here I have one picture of a patient who had apical cardiomyopathy because endocardial delineation is poor, sometimes missed here actually. Contrast echocardiogram plays a role and producing this spat-shaped cavities. Spat-shaped cavities and separate apical cardiomyopathy, Yamaguchi syndrome is a separate type of a cardiomyopathy, a phenotypic variant here. Here I have a patient, a 50-year-old male, presented with symptomatic status here actually, angina, chest pain, an exertion, dyspnea, class 2 with history of an episode of syncope, and CVS examination with systolic murmur here over the left intercostal space, and asymmetric septal hypertrophy with the SAM there actually. Posterior jet MR, which is very significant. Here, look at it actually. It will produce a lot of the contamination when you measure this actually, because almost this gradient collides with the MR. There is a significant SAM actually, and there is abrupt systolic closure of aortic valve reflect with the fluttering here actually. There is no aortic valve involvement. And ejection fraction, look at it actually, it is overestimated. It is estimated as 88, and when you use the Simpson formula, it is 61. And it is also a sort of a reverse curve there actually. And we have a turbulence across the LV outflow. And we have some amount of MR contamination, gradient is 53, provocative to 60. And we have a diastolic abnormality by the inflow Doppler. And tissue Doppler velocity is reduced. There is a turbulence there actually with MR contamination. LA volume, look at it actually, 75 ml. There is significant diastolic the abnormality there with the strain showing an extensive involvement, and the global average strain is -14.5. So he is asymmetric septal hypertrophy, reverse curve, septal thickness measuring 26. IVS to positive wall diameter is 1.56, SAM grade 3, LVOT rest gradient is 53, mitral regurgitation. This is a form of HCM with LVOT obstruction. And we have any unexplained maximum thickness more than 15 in any segment confirms the diagnosis. Septum to post wall thickness more than 1.3, normotensive more than 1.5, and hypertensive also a diagnostic of hypertrophic cardiomyopathy. I gave you all this actually. We have a neutral type, we have a sigmoid variety, which is commonest 50%, and the reverse curve we have a 40%, And genotypically, it is significant. Sigmoid is lead gene positive 10% and reverse curve 80% gene positive. Apical variety and neutral type, it is 30 to 40% gene positive. But in commonality, it represents less than 10% of the hypertrophic cardiomyopathy. They may come with a non-obstructive state in 30% and latent obstruction in 40%, where the provocative maneuver produces gradient of more than 30, and resting obstruction is 30%, where resting state is more than 30 mm. More than 50 mm, it is significant. It needs to be differentiated from athletic heart. Athletic heart is little different morphologically. They have a symmetrical LVH, LV curve dilatation of more than 55 mm. Actually, there is a normal or supranormal systolic and diastolic tissue Doppler velocity. In hypertrophic cardiomyopathy, the LVH is ASH and unusual pattern. Cavity size is remarkably reduced with an abnormal LV filling, with a reduction in systolic and diastolic tissue Doppler velocity. Actually, screening is very important. Actually, it is one of the IAE recommends screening for people who have a relative patient with hypertrophic cardiomyopathy, optional less than 12 years, and age up to 18, adolescent state 1 to 8 months. You have to screen them actually. In adult, at least every 5 years, and high risk status, you have to use them very frequently to detect it actually, because expression can be later. And you have to look at the high risk people with sudden cardiac death for indication for ICDs actually. These are the flow charts showing people needing this. Extensive late glomerular environment CMR become an indication for ICD. These are the high risk individual for sudden cardiac death. Recently, we can look at this actually. Genetics of hypertrophy is evolved. We have established emerging implications in clinical practice, and this can be used for diagnostic confirmation. This can be used for familial cascade screening. It can be used for polygenic risk score, and also it can be used for targeted therapy by pharmacogenomics and tailored gene therapy. This stratification is very important. Differential diagnosis here. Morphologically, little more different type of LVH. They have aortic stenosis, hypertension. Strain plays a role in detecting all these things. Athletic heart difference, I told. You should also keep tumor invading the IVS as a differential diagnosis. Attached mural thrombus and posterior MI, when posterior thickness is reduced due to the infarcts and the ratio alters actually. These are the AAC recommendation. Morphologically, echo plays a very important role. The MRI is indicated when echo, the measurements are suboptimal, or you have a doubt in confirming the diagnosis. Only state for a morphology, MRI is indicated, and systolic and diastolic functions can be assessed by various echo parameters. We have Doppler, conventional Doppler, tissue Doppler, pulmonary venous Doppler. We have the LA volume assessment. We have various criteria put forward using all this parameter. LVOT obstruction can be carefully assessed only by this echocardiogram, but MR contamination has to be kept in mind actually. And the spectral Doppler will give you an idea on associated coronary disease. So these are the predictors of sudden cardiac death. I would end my lecture by saying this AAC recommendation, echocardiography evaluation is important. Presence of hypertrophy distribution should be reported. LVEF has to be reported. Reduction in EF is high risk status. RV hypertrophy, you have to carefully look at the RV obstruction. LA volume indexed body surface area is a must. LV diastolic assessment, you have to do multi-mode to assess the actually pulmonary arterial systemic venous pressure, will give you an idea of associated high risk status. Dynamic obstruction at a various level, you have to do at rest and also Valsalva maneuver. Mitral valve and papillary muscle is important. Directional mechanism is important actually. Sometimes when you could not assess this, we need to suboptimally, you have to use the TE. TE is recommended to get surgical myomectomy, and screening as recommended has to be done for a high risk individual. Thank you so much for giving the opportunity, IAE. Long live IAE. Thank you, sir.
Thank you, Dr. Jawahar Farooq. Now, let us hear from Dr. Majella regarding the cardio-obstetrics of prosthetic valve management during pregnancy. And meantime, when you are looking into the YouTube of Indian Academy of Echocardiography, below the video, you can see the details of Indian Academy of Echocardiography, how to become member of IAE, and the privileges of members of IAE. So let us hear from Dr. Majella.
Respected seniors and dear friends, a very good evening to one and all. I thank IAE President, Secretary, as well as Professor Amudan Sir and Selvarani Ma'am for having given me this wonderful opportunity. Today, we are going to see the echo assessment of prosthetic valve thrombosis in pregnancy. It's a huge topic on its own. So I would like to take an important case which has taken all of us into a roller coaster ride. Coming to the clinical details, a 23-year-old female, primary, after 5 years of married life, now has conceived, who presented with dyspnea class 4 on 2/1/24. Her LMP was 21/23. That is, she was just around 2 months and 4 days. That is roughly around 10 weeks. She had already underwent a mitral valve repair in 2010, where the exact details were not available. Now, she has underwent in 2012 a mitral valve replacement, St. Jude's valve. The exact size of the valve was not mentioned in the reports. We could get it only a little later. The exact size was not mentioned in 2012, and the post-op gradients was mean gradient of 6 and peak gradient of 16 at the level of the mitral prosthetic valve. The pre-pregnancy patient was on acetylene 2 milligram and 3 milligram on alternative days, and her INR was maintaining between 2 to 2.25. She had a history of CVA involving the right upper limb and lower limb on 19/12/23. That is almost just 2 months, that is 8 weeks after conception. She was treated at a tertiary care hospital in Chennai, and MRI brain revealed left MCA territory infarct. At that time, she was advised injection heparin 5,000 units subcutaneous BD and was discharged from there. Then, in between, the patient having taken a proper treatment, she has discontinued drugs, now referred to our center, Omandurar Multi-Super Specialty Hospital, with class 4 dyspnea, almost in a stage of about to get arrested. Patient was unable to lie down with acute right lower limb pain. Her heart rate was 130, respiratory rate was around 40, saturation was 90, and BP was around 96/60. The PTINR was just less than 1.78. So when a patient coming with prosthetic valve thrombosis, we know coming to the middle and the lateral in the mitral position, we need to see the mean gradient, the peak velocity, mean velocity, the effective orifice area, Doppler velocity index, pressure half time, as well as the pulmonary artery pressures, pulmonary artery gradients, the LV function, RV function, chamber enlargement, how is the valve opening, closing, whether there is any thrombus, are we missing out a pannus, the short axis, especially of the aortic valve, so all these things has to be in mind. And we have to note that if the peak velocity is more than 2.5, the mean gradient is more than 10, and an effective orifice area of less than 1, and if it is indexed to the body surface area less than 0.8, less than 1, and a DV, Doppler velocity of index of more than 2.5 in the mitral valve, and a pressure of time of more than 200, definitely a prosthetic valve thrombosis is suspected. But we need to differentiate also from patient prosthetic mismatch. And that is where the effective orifice area indexed to the body surface area plays a very important role. An effective orifice area of less than 1 centimeter square, effective orifice area is actually calculated by the stroke volume divided by the prosthetic valve PTI. So if it is less than 1 in the mitral valve prosthesis, definitely it signifies a significant obstruction. But with normal gradients or abnormal gradients, then we have to suspect a patient prosthetic mismatch. Also, the pressure of time, if it is normal in the presence of higher gradients and DVI, once again, a patient prosthetic mismatch should be kept in mind. With all these things, but in such an emergency situation, it is practically not possible to go into all the details. Patient is about to collapse. We are in a hurry. So we did the transthoracic echo. The heart rate was average roughly around 130. We couldn't measure, but with the rough idea and with the mean gradient of 32, peak gradient of 45, a Doppler velocity index of 6.9, and normal LV function, but the RV function was very much reduced, and the TRPG was 52, and it was underestimated because of the RV systolic dysfunction. A very quick echo was done, and we didn't even take the ECG initially. A DV of 6.9, we know definitely it is not a pannus, it is a thrombus. We are able to assess it, and the INR is very low. This is the echo, quickly a short axis to assess the function. I'm putting few videos to assess the restricted opening, and since in the prosthetic valve, we are able to see that because of the echo dense area and the LV, in the LA, we won't be sometimes very difficult to look into and catch a thrombus there, where the TE is very useful. But in such situations, we have no other options. Now we are unable to put in a TE in such conditions. The mean gradient is 32, peak gradient is 44, the VTA is 104. We are able to clearly see the restricted mobility. In the zoomed view also, we are able to see there is RV dysfunction. So we are a quick assessment of the IVC size I had done, but I didn't take the expiratory collapse. Inspiratory collapse I didn't do because it was very quick, just to assess the hydration status of the patient. And quickly we took the patient and immediately got the CT scanner. But even before that, we started on lysis for the patient. We had given streptokinase, and not going into the detail aspect because it's an echocardiography topic, but we gave a streptokinase. She was just in the first trimester of pregnancy. We have no other option. We had given lysa with injection streptokinase 2.5 lakhs loading dose, followed by 1 lakh per hour, and we closely monitored the gradients gradually, so that when it comes down at least to normal, we will be able to stop the lysis. We had given a written consent, video consent, a young female, precious pregnancy. Coming at this stage, though we know all the echocardiographic parameters, we are unable to do so. So a quick assessment of the Doppler velocity index, 6.9, it's very, very important, especially if the patient doesn't have an aortic regurgitation. DVI is very useful, especially in mitral, aortic, and tricuspid valves, prosthetic valves. Definitely, it's an important assessment. Because the heart rates can still cause a higher gradients. This was taken into consideration. Patient lies, and following lysis, slowly the gradients started coming down. And very important, the patient had the LVOT VTA was taken, then the DVA was gradually coming down to 5, then gradually coming down to 3. And once it came to around 2.8, which stopped the lysis, patient, though, after the first, had severe pain, even on admission. The right lower limb pulses from the femoral were very feeble. So we immediately called for a vascular surgeon opinion. They did the Doppler and found out that she had a shower of thromboembolism into the right lower limb also. So young female, pregnant, with CVA, now with prosthetic valve thrombosis, and with the acute lower limb arterial thrombosis, which really patient is having very feeble pulses, and she was having severe claudication pain. So after thrombolysis, the gradients have come down. The vascular surgeon said, "Madam, we have lysed the patient. We are continuing the lysis. Just give us 1 day. Tomorrow we'll take up." So after the lysis, they had to take up for surgery. And there was thrombus extensive from the right common femoral artery, femoral artery, superficial femoral artery, right popliteal artery, at the anterior tibula, and the posterior tibial trunk was loaded with thrombus. And this is the perioperative images of this patient, 23-year-old, whom with the Fogarty catheter, they were able to remove the thrombus, and the flow was established acutely within this, on the second day. The first day there was lysis. This was the second day. Patient, gradually the pain settled. She was slowly settling down. The respiratory rate came down. She had respiratory rate came down. We were watching for any bleeding manifestation anywhere. She was on heparin, followed by heparin 1000 units, international units per hour, and slowly we are able to see. You are able to see that the valve movement slowly it is coming, and we are able to, in the parasternal long axis view, we are able to see that there are not much turbulence has reduced completely. The echo images are very poor quality. I really apologize because the patient was very sick and we were not able. Here is the image where you're able to see that the mitral valve is opening, prosthetic valve is opened up well. And this is on 18/6/24 that the patient was almost there for 1 month. That is from January till February, January end, she was there completely. And gradually we were following her up completely. And these were final gradients, 6.9 and a peak gradient of 10.3 and a mean velocity of 1.28 and a peak velocity of 1.6. And the TRPG has come down. TR was trivial pulmonary hypertension. Fetal echo was monitored continuously. There was a viable fetus. An anomaly scan was done. It was normal, though there were a lot of deliberations on MTP because it was the first trimester of pregnancy. But what we recommended was we'll do a fetal echo, we'll do an anomaly scan. Anyway, it's going to be high risk. She's loaded with streptokinase and anticoagulants. So at that time, even an MTP will be a high risk for her. We explain to the patient and the attender, and if it is because after 5 years of married life, she has conceived, but still, if it is not going to be a viable fetus, I would like to very much thank our OG colleagues who visited daily the patient, and if daily they will be given a call over to see the viability of the fetus, as well as to assess any draining or PV gynecological examination. Anomaly scan was done, it was normal, and at discharge she had a mean gradient of 8, an average mean gradient and a peak gradient of 15. Everything was settled, a DV of 2.8, and patient has delivered by LSCS, giving birth to a 2.09 kg male baby. And the baby is fine, the mother is fine, but she has got a, I'm telling it in a very short way, but a very labile INR. The assessment of prosthetic valve in pregnancy needs a lot and lot more apart from the routine. We have to monitor the labile INR, catch them earlier before they even develop a thrombosis, and take us for both the patient and us and the attenders going for a large roller coaster ride. So the prosthetic valve's importance is we have to get a proper information. Quick one should get a quick information. One is doing the echo evaluation. The other one is fully examining the patient from head to foot, because on the same day we diagnosed that she has also had an acute limb ischemia. She was treated outside but referred to us. So there are many these things that has to be taken into account in such patients. So prosthetic valve thrombosis is very challenging during pregnancy. This is for this patient, I'm telling you, and it is for all. So though our primary focus is in the heart, we also need to look into other systemic and thromboembolic complications. Periodic maternal and fetal echo is mandatory. A very labile INR, not the routine of every 3 weeks, has to be taken. It has to be done even every week or even 2 to 3 days. The patient's INR suddenly goes to 3.6, then comes down. So she was maintained on almost 3 and 4 milligram of warp on alternate days. And the EAC guidelines clearly say that if it is less than 5 milligram, the fetus anomalies doesn't occur because of the anticoagulants. And multidisciplinary team is the key for good outcomes. Pre-pregnancy planning and counseling and an echo pre-pregnancy itself will help her to sail through pregnancy without complications. So coming to the practical, the theory part of it, just a few slides before I conclude, because I want to highlight the importance of the patient, because though we know everything, on the spot management becomes a big deal. But for the general assessment of the prosthetic valve, the date of valve replacement is very essential. The type and size of the prosthetic valve is very essential. Height, weight, body surface area is very essential. Symptoms and related clinical findings, auscultation, simple auscultation that we are not able to get the click, whether there is a functional regurgitation or a pathological regurgitation, depending upon the closing, all these things has to be assessed. And in the echo, very important also, the closing angles, the opening angles, all these are very important. The opening and closing of the leaflets or occluder, the presence of leaflet thickening, calcification, abnormal densities, the valve sewing ring, the position of the ring, and others, as mentioned, estimation of the pulmonary artery pressures, venous inflows, the atrial size and function. And always remember, transthoracic echo is of very vital importance, but TE is frequently needed in many patients. When coming to the aortic prosthetic valve, here we have seen the mitral prosthetic valve. So when we have to see when there is a significant stenosis or not. When the mean gradients are more than flow, the effective orifice area becomes less than 0.8, and the index effective orifice area. Once again, I told you, the effective orifice area is stroke volume divided by LVOT divided by prosthetic valve VTI. When it is indexed to the body surface area, that is why in echocardiographic assessment, the importance of body surface area becomes a major role, because effective orifice area in obese individuals more than a BMI of 30, the estimation varies. So it is very essential to take to keep it in mind, this effective orifice area, especially in patients with BMI of more than 30. Therefore, we have to always, it is indexed to the body surface area. And in aortic valve, if it is less than 0.6, index is very significant, and a Doppler velocity index less than 0.25. In mitral, the DVI is taken from the mitral prosthetic VTI divided by the LVOT VTI. Whereas in aortic, we take the LVOT VTI, the aortic LVOT VTI divided by the aortic valve VTI, that is proximal by distal. So if the DVI is less than 0.25, it is significant stenosis, and an acceleration time of more than 100 in aortic valve bioprocesses indicates a severe stenosis. As I mentioned, in patient prosthetic mismatch, the acceleration time is not that much increase. It is usually normal. So these are the calculation of the DVA I've already shown in the previous case. We assess the gradients as well as the here the LVOT VTI divided by the aortic valve VTI and the acceleration time. So a young woman presenting with valvular heart disease, very early diagnosis, patient pre-pregnancy assessment is very essential. Then whether it is a mechanical prosthetic valve or a biological prosthetic valve, and the gradients, everything has to be assessed. We definitely know we have got a lot of mechanical valves. Sorry, what is the type of valve should be individually assessed, and whether it is a bioprosthetic valve, and especially in this scenario of tower and other things, we should keep in mind all those things, all the valves, which are the possibilities, and assess them individually. And before I would like to conclude, I would also like to mention the pressure recovery phenomenon in prosthetic valve. The schematic changes in velocity and pressure of the valves. The velocities are lower and systolic arterial pressure is higher to the at the distal aorta when compared to the vena contracta. So the left figure represents the change in velocity and pressure of So this is a very important phenomenon. We have to assess the gradients, and especially in patients when the aorta is less than 3 centimeters, this pressure recovery phenomenon plays an important role. So remember, pressure recovery phenomenon in patients with aortic valve less than 3 centimeters. Sorry. And thank you. This was by the patient, a miracle pregnancy for the patient. And they always come with a ray of hope that we should do something possible for the patient. As Amudan sir rightly mentioned to me, it should not be a didactic lecture on prosthetic valve thrombosis because everyone knows about it. A case-based approach would be the right for the thing. That is what sir had mentioned. So I thought I'll take you according to the case. And I thank sir and IAE and ma'am and everyone for patient listening and giving me the opportunity. Thank you.
Thank you, Professor Cicely Mary. Now I request Professor Selvarani to take up the question answer session. There are a few questions in the chat box. Please conduct the question answer session.
Yes, sir. So the first question they have asked is regarding hypertrophic cardiomyopathy, whether the dagger shape can occur in hypertension. Zawar Farooq, sir. Whether
So,
dragger shape occurring
mechanism of scimitar dragger suggestive of a dynamic LV outflow obstruction. So the dynamic LV outflow obstruction means there should be initial contact, initial part of it. They may not have a flow restriction as in patients with basal septal hypertrophy. And when the undermetrial leaflet move towards the septum, there will be increase in the gradient, and it ends before the systole and move out of this actually. So hypertension also, when there is a basal obstruction, some of the reports suggest that there can be a gradient when there is significant the hypertrophy occur in the basal septum. There are some report has been reported. This is one of the differential diagnoses.
Yes, but other findings will not be there.
Other findings will not be.
A diffuse type of hypertensive cardiomyopathy, the very much differential diagnosis is severe hypertension, uncontrolled hypertension. It, as you rightly pointed out, the basal septal hypertrophy, especially in the old age sigmoid-like septum, etc. And next question is whether it can present in the normal in the birth and it can appear later because it is a genetic spectrum.
Yeah, it can be expressed later actually. Genetically, positive status can be occur in 30 to 60%. And the commonest the gene expression involved is, the myosin heavy chain protein 3. And myosin binding protein C3 is the MH7 is the one which is commonest. And MH binding protein C3 both contribute for 75%. And gene positive status is 60%. It can express later. One of the important findings people have reported here, in the you can have a normal echocardiographic finding with genetic abnormality, especially when you have an expression of cardiac troponin, which expresses later the present with the high-risk features of hypertrophic cardiomyopathy.
Thank you, sir. I would like to add few points.
Sir, Majella, you can stop sharing this screen.
The apical part, apical hypertrophy is sometimes missed during the routine echocardiography, and sometimes very difficult to differentiate between the hypertensive cardiomyopathy and hypertensive heart disease. And some have calcification. And later part of life, they will have burnt out case mimicking the dilated cardiomyopathy. And myocardial bridges can be associated. And there may be CAD. We have a couple of cases recently. We have done angioplasty. And we have a registry in our department, the combination of HCM and CAD. These are all the things I want to add. And syndromic type can occur in Noonan's and other syndromes, yes. And unknown etiology can occur even though it's autosomal dominant, 1 in 500 incidents. So these are the things regarding the hypertrophic cardiomyopathy. The questions to Cecily Mary Majella. It's a nice case. It would have been better. Transesophageal echo is done.
And the patient was very sick, ma'am. She was very sick. She can't even lie down. And in this situation, even transthoracic echo, we couldn't do properly, madam. She was very in a very bad shape. Thank you.
Yes. And then post-op anticoagulation strategy for this, what you have done?
Yes, ma'am. We had put her on heparin for almost 15 days. She was on heparin with monitoring the APTT, madam, because she has underwent arterial thrombectomy also. So we, in conjunction with the vascular surgeon, she was on heparin 1000 international units per hour. And she was, after she was completely stabilized, we slowly bridged her with warfarin, madam. Warfarin, according to the ESC recommendations, if it is less than 5 milligram, definitely the fetal, the outcomes are better. The incidence of fetal abnormality, fetal embryopathy, warfarin-induced embryopathy is definitely on the lower side. So we gradually shifted her with, bridged her with warfarin therapy, including the first trimester. She was on warfarin, but she had a very labile INR. We monitored the INR almost every 48 hours. during admission. And when she got discharged, every 3 days, she was asked sometimes to do the INR because suddenly it went up to 3.6, then coming down to 1.8. And even now, after delivery, she's on heparin. Today also, I went and saw that patient. I think from professor from MMC, Professor Justin Pulsar is also following her up. And the MMC team is also following her up. She was admitted during the acute crisis in Omandurar. Until the 36 weeks, she was under our follow-up. Then she was referred to IOG for labor and delivery. And she was maintaining, but now her INR, latest INR was only 1.3. In the hospital, it was 1. Done outside, it is 1.3. She's on heparin, 1,000 international units, as well as warfarin 5 milligram. But her INR hasn't picked up yet. But she's stable, no bleeding complications, nothing. Prosthetic valve click is made out. Her echo gradients are normal, madam.
And they have congratulated you. In a given situation, the case was excellently managed by you. Congratulations.
Madam, not by me, but by an entire cardiology, obstetric team, MMC team, and the IOG team, madam, KGH team.
Everyone. Yes. And the signature gradient, what you have told, is very important. It depends upon the prosthetic material we use and also the patient criteria. So that is also there. And then sometimes the bioprosthetic valve in the aortic position. We had one experience. Somebody has started on anticoagulant and patient, even after mentioning to stop it, somebody was continuing. So such fallacies can occur in our day-to-day practice. And you have to be very careful to pick up paravalvular leak. Recently, we did a paravalvular leak closure tie device. We have done 3 cases in our department, and we have presented also. And that is also there because as sir was telling some turbulence, many turbulence flow and mosaics may be seen. So very careful evaluation. So even if you have a very subtle doubt, you have to subject the patient for transesophageal echo. That will give a very clear idea about the valve anatomy, thrombus, vegetation, pannus, and some of the torn suture materials and the cordae, etc. So we had a very great discussions, and I think there is no more questions. Over to Amudan.
Thank you, Professor Selvarani, for conducting the question answer session. Now, we had a very excellent session on pleiotropic manifestations of hypertrophic cardiomyopathy. And Dr. Jawar Farooq showed you all the types of hypertrophic cardiomyopathy. I would like to stress on one point, especially in non-obstructive hypertrophic cardiomyopathy, which in youngsters, which may pose problems in differentiating from athlete's heart. Now, do you think, how do you differentiate this? You can say a few words about that. Athletic heart and...
that I've shown, sir, actually, symmetrical involvement there. And there won't be any cavitary dilatation, actually. The cavitary size will be, the athletic heart will have a dilated LV cavity. You don't have the tissue Doppler showing this systolic or diastolic reduction in this, the gradient, whatever we saw.
Cavity reduction may not be there.
It may be there.
And the cutoff is 80.
Most important thing, strain echocardiography will be differentiated.
Strain.
And you can do the genetic markers, which will be of help. Professor Cecily Mary has done an excellent job of managing an excellent case. And what was the outcome? How is the baby and mother now?
So both of them are fine. Even today, I visited them at IOG, sir. Both of them are fine, doing well. But the INR is on the lower side. So they are on heparin infusion, also 1,000 international units per hour, as well as on VAR 5 milligrams. But echo gradients are mean gradient only 6 and peak gradient around 12 or 16 or 14, sir. To their normal DVA was only 2.2. They are doing well. Both mother and baby are doing well.
informed that they are doing well, you can proceed with the transesophageal echo and you can show better images in future meetings.
Sure, sir. Sure, sir. Sure.
So, Dr. Manish Bansal, sir, shall we close the session? Both the speakers did an excellent job and we are on time and there are no more questions. Shall we close this session, sir?
Yes, sir, please.
Thank you, sir. We'll close this
Thank
session.
you. Thank you so much.
We would request Dr. Majella to present the TE appearance in one of our future meetings, which is coming
Sure,
on
sir. Sure. Sure. Sir.
27th.
Thank you. Thank you very much, sir.
Thank you. Sir.
Thank you, everyone. Thank you.
Thank you, ma'am. Thank you.